At the outset, I'd like to thank Dr. Praful Maharana for giving me this opportunity. And since most of you are students, so I'd like to go stepwise. And then, though it is mentioned at DSEAEK, that is a Descemet stripping, automated endothelial keratoplasty, but I am doing manual dissect. So I'll stick to my method of doing. Basically, as we discussed, the endothelium, which is responsible for maintaining the detrusence of the cornea, it gets you develop bullous keratopathy. So only that layer is replaced. This is component replacement surgery. All you have to do is just endothelium with a Descemet's membrane, and about 100 to 150 microns of the stroma is taken in. And then you have other modalities of treatment also, like DMEC, then there's PDEC, so all these things. So, but this is what, so now the indications are all those conditions where the endothelium is defective. So probably following cataract surgery, which results in pseudophakic bullous keratopathy, which is of late, the incidence has come down so much because of good viscoelastic substances and good technology, that is phacoemulsifiers. And then this is another important thing which may not be very common, but still that can throw surprises post-operatively, especially when the endothelium is not healthy in Fuchs endothelial dystrophy. So you have done uneventful surgery, and next day, to your surprise, you see a lot of edema. So probably if you just look pre-operative evaluation with the corneal, specular microscopy, it'll tell you all these things. And then it's important to know about this for various reasons, whether to do the cataract surgery and do the dissect at the same sitting or not. Anything less than, if the patient is younger than 40 years, then you can do only dissect if there is this thing. If the endothelial is decompensated, or if it is more than, if the patient is more than 40 years, then you can combine cataract surgery along with the DSEC, okay, or DMEC, endothelial keratoplasty. And then sometimes the endothelial rejection, which is very common in following post-penetrating keratoplasty, is that there is the worst type of disease that we can have. Graft rejection, it can be graft failure also because of defective endothelium. You can do this. And then the contraindications are in case if there is significant scarring in the center. So only endothelial keratoplasty is not going to help at all. And then if following previous penetrating keratoplasty, if there is irregular astigmatism, or if there is high astigmatism, again it's not going to help. So what is the pre-op evaluation? This is basically to decide, to plan the surgery. If the patient has got cataract, you'll have to plan along with the endothelial keratoplasty cataract surgery also, if there is a significant scarring or not. Sometimes it may look white, but if you do anterior-segment OCT, you will come to know that it is only the epithelium which is edematous. Underneath the epithelium, the stroma is clear. So all you have to do is debride the epithelium, and you can go ahead with endothelial keratoplasty. If there are iridotomies, or if there is aphakia. Why aphakia? Because the air tamponade that we use, the air tends to go into the vitreous cavity, and then that can result in the graft dislocation. So better to correct aphakia, and if peripheral antisynecia, you will have to correct that. If there is vitreous, again you will have to plan for antivitrectomy. So now coming to the instrumentation that we have, this is very important. This is the most important thing is this artificial antechamber. This is the base, and then you have a pedestal. At the top of the pedestal, you can mount the corneoscleral button, which is around 13 to 14 millimeters. And then you have a locking tissue retainer, and then there is a locking ring here. So it's available both as a disposable as well as the reusable things in steel or the platinum with the metallic artificial antechamber. And then the instruments that we use for dissecting the cornea at the plane of say around 400 or 450 microns is this. So these are the blades which are used. Now every company has got its own design. Now they are also available as the disposable things. And then you have the reverse Sinski hook, which is to strip the Descemets, because the DSEC is Descemet stripping endothelial keratoplasty. You can use 26 gauge needle also. We'll see the video later on. And then depending upon the type of insertion of this lenticule, that is a donor's lenticule, then we have either the forceps where you can hold it, at the tip has got curvature, then you can use boosting glide, then there are a lot of endo inserters. Based on this, there are a lot of techniques, whether you can fold the thing into the form of a taco and then place it so that the stroma goes up and then it opens up the endothelial side down, or you can push the whole thing, which I'll show, and then depending upon the type of thing that you instrument that you use, either boosting glide or the endo inserter, you can have the surgical technique. So now I'll just show you the push technique, which is simple, and this is the artificial antechamber onto which tissue is mounted, and this what you are seeing here is the preset knife. So you are going to make an incision at the corneoscleral junction, which goes up to about 400 microns or 450, depending upon what knife you are going to use. It's always ideal to use, say, anything more than 400 microns, because the corneal tissue is, say, in the center. If you take as 500 microns, in the periphery it will be somewhere around 800 to 1000 microns. So if you start at 400 microns level, then probably you will be having 100 microns in the center. So once you dissect this, so now you have made a cleavage. Now you are going to make a plane. This is exactly at the 400 microns. So better to lift the tissue and then you start there. And this is the dissector. So this is a disposable dissector. So your idea is to dissect at that plane from end to end, that is from limbus to limbus, 360 degrees all round, so that when you punch the corneal button, so there are no attachments anywhere, and then you make a mark on the epithelium, so that acts as a guideline. So that can be stained with the trypan blue, and then this is the reverse Sinskey hook, with which we are going to strip this. So that is called the endothelial scoring, the Descemet scoring, and then you can strip the Descemets. It's very easy when you do cataract surgery because that is how the Descemet behaves. It gets stripped, but while stripping sometimes it may not come so easily. So all you have to do is just strip the Descemets. See, here I showed you we are injecting visco, but it's ideal to avoid visco. So paracentesis is made exactly 180 degrees apart, and then once you strip the Descemets, you enlarge the incision. This is the scleral tunnel, and then the stripped Descemets is taken out. Okay, so now this is the cornea without Descemet's membrane and endothelium, and now, so once you make this, push it like that with the needle. It can be done under air, but ideally it should be done under saline. Okay, and then the air as the tamponade, so it goes and makes the tissue stuck to the. So this is another case. You just see this. So you can make. You need not make a scleral tunnel. You can make a clear canal or at the limbus incision. Then two paracentesis on either side, and then under the saline. So now you are extending with. So this is the 26 gauge needle. The tip is blunted against a rough surface, and now under saline, under BSS, so you can start scoring the Descemets on either side, and then you start stripping that. Now the problem with this, even though you have blunted the tip, still it can go and stick to the stroma. So finally, now the diseased endothelium is removed. So that is a diseased endothelium, and then the pre-placed sutures. This is what I used to do earlier. Now put viscoelastic, preferably a chondroitin sulfate, with the endothelium down over the tunnel, and now using the same 26 gauge needle, you can just push under the saline itself. So now you can see the lenticle which has gone in. Now under the lenticle, you are going to push air so that that pushes the whole thing up against corneal stroma. So now it is better to suture the wound so that air doesn't escape with the pre-placed sutures. And now the interface, if at all you want to adjust the graft, okay, or if there are some debris, you don't want anything in the interface because that can result in inflammation. And so this is the end. It is very simple, not difficult. So now, but still, see, the follow-up is similar to penetrating keratoplasty, but there are complications associated with this also. And then the air that we inject, that I'll come to this little later, their graft can get dislocated. This is one. There can be primary graft failure in case if you are going to damage the endothelium while inserting with any of the methods. Again, that can, and graft rejection is, can also occur because the endothelium, elevated intraocular pressure. This is what we'll have to take care, especially with so much of air injected in the antechamber, that air can go through the pupil and can cause pupillary block. So you will have to, after 1.5 hours, you better to examine the patient and then remove some amount of air through the side port so that the pupillary block can be avoided. And of course, there can be infection like in any other case. And then graft can get dislocated for various reasons in case if at all you are using any viscoelastic substance. Which viscoelastic is advised? Suppose patient undergoes cataract surgery along with endothelial keratoplasty, any cohesive viscoelastic substance like sodium hyaluronate can be used so that it comes out very easily. And then there is improper positioning of the donor disc, or there can be delayed endothelial pump, because if the donor endothelium is not healthy, or for whatever reason you have damaged so much that and primary graft failure can also result in dislocation. Or in case sometimes, since it is going to be very thin, you don't know which is endothelial side, which is epithelial side, which is stromal side, then the endothelium can go up and stroma can come down. So your endothelium will not function properly. So donor disc again is going to get dislocated. So in a nutshell, it's a very less expensive and very rapid, faster visual recovery and easier surgery, and this is the effective way of correcting endothelial decompensation, provided patient doesn't have the scarring of the anterior surface. Okay, so the results are better than penetrating keratoplasty because there are no sutures here, and then the graft rejection chances are also much less as compared to the penetrating keratoplasty, and the results are of course are reproducible. So, thank you very much. Thanks for the patient listening. Thank you.
Thank you so much for that. Was a basic talk for you all PGs. Okay, so whenever you are planning for endothelial keratoplasty, the first step is always manual desec. Once you master that, then automated, then demec. So with this, I think our next session is ready. We are ready with our expert panel and moderator. Thank you so much, Satyamurthy sir.